Good day, everyone. My name is B.J. Whitman, and I'm chair of the Board of Ethics and Professional Standards, and your host today for this webinar. Thank you for joining us today for a world-class webinar where you will hear about relentless commitment to ethics and transparency, which continues to make a difference in our lives and health of communities. Our facilitator, Dr. Rhoda Weiss, is past PRSA National Chair, Gold Anvil winner, Health Academy Lifetime Achievement Awardee, and Educators Academy Ferguson honoree for contribution to public relations education. Also, Lifetime Leadership Awards from Michigan State University, Women in Health Administration, American Hospital Association, and the U.S. Air Force Distinguished Public Service Award, its highest civilian honor, plus UCLA Extension, outstanding faculty, and many, many more accolades. Among the nation's best-known healthcare leaders, as co-chair of Becker's healthcare conferences, which just had 13,000 virtual registrants, Rhoda has done in-person and virtual interviews of over 50 top CEOs. In addition to her consulting firm activities, she chairs Health Market Leaders, 110 CMOs and CCOs, representing majority of U.S. hospitals that met 135 times since the pandemic began. In LA, she founded and leads Better Together Health, uniting 5 competitive health systems that pivot resources to create massive public service campaigns, encouraging people to timely access needed care, featuring patients who did just that, fight life-threatening diseases to return to things they love. And now our moderator today, Rhoda Weiss.
Hello, everyone. For nearly 20 months, we in healthcare have faced an excruciating crisis that no crisis plan could have ever fully prepared us for. We also face the greatest ethical dilemmas of our careers. If this pandemic continues, if people stay unvaccinated and unmasked, if disinformation and misinformation remain unabated, offering comfort and cause to the unvaccinated, then by year's end, we'll reach 1 million US COVID deaths. We'll discuss these and other issues with our national thought leader, Dr. Tony Slonim. Tony is the renowned health CEO. He's a sought-after speaker, a notable career as a nurse, a physician, an intensivist, a doctorate in public health, healthcare executive roles in the private sector, in government, academic medicine, and public health. Dr. Slonim, Tony has done it all. He has been named to the 50 most influential clinical executives in the US. He is author of 16 texts and 60 academic journals and editor of Physician Leadership Journal. He joins the American Hospital Association Board of Trustees next year and currently chairs its Health Systems Council of more than 300 health systems. Renown has 4 hospital campuses, 120 sites, is affiliated with medical schools at Stanford and University of Nebraska, has a health plan with 230,000 members, is a regional referral center for 100 miles between Sacramento and Salt Lake City. His body of work has not gone unnoticed. In December, the Wall Street Journal profiled him and the heart-stopping professional and personal challenges he faced. In the article, the journal rightly said what we're all living 24/7. For many leaders, the great pandemic has been the mother of all anomalies, a blur of bizarre, impossible, and potentially defining decisions, often made in a hurry with no practical frame of reference. Every time we get better of it, another surge hits with unspeakable possibilities of health rationing rearing its ugly head. We set vaccination mandates. We face staff shortages, burnout, unhappy and highly vocal opponents who do not believe in masking or vaccinations. We try to counteract disinformation and misinformation, which unfortunately has become the norm, and have no answer to those of us, people who tell us to have a nice weekend. To make it worse, with millions of people putting off needed doctor appointments, screenings, and care in general, we're facing a silent epidemic and a nightmare of late-stage cancers, advanced heart disease, debilitating strokes, putting off kids' vaccinations, uptake, and dreaded measles, and much more. We have learned lots. Today, Tony will share his challenges, his wonderful work in diversity, equity, inclusion, and access, the future of work, creating populations of health, early disease detection, sustaining rural health, philanthropy, keeping community services alive, and so much more. Welcome, Tony.
Rhoda, it's so great to be here. Thank you, and BJ, for inviting me.
Thank you. Tell us briefly about your journey from age 8, when you were taking blood pressures of visitors in your parents' home, to where you are now, and how your career and some health issues also impact who you are today.
Thank you again for inviting me to participate. It's always great to be with you and share some wonderful stories about not only about life, but about some of the challenges that we're facing. And for me, understanding and coming and rising above challenges is many of the ways in which I've had those experiences, as we all have in different ways in our lives. And from the time I was 8 years old, all I ever wanted to do was be a physician. My daily mission, even this many years later, is to restore people to health and to keep them healthy. If they get sick or injured, let's restore them. If they're healthy, let's keep them that way. And it's really funny how I ended up in healthcare. I didn't actually have any family members that were in it, but my mom used to go to, we lived in a lower middle class community, and she would go to all of these big mansions, often owned by doctors, and bring me home at their estate sales these medical textbooks that she would buy for $1. And my room was lined with them. And I would look through them and read and pick things up. And it's all I ever wanted to do. And so how fulfilling and how wonderful it is to get to realize your dream. And that's what drives me every day is I'm privileged. I'm privileged to know and do the work that I do on behalf of so many. And so just enjoy the ride while we're at it, and we'll see where we go.
Thanks. During COVID, you had a personal tragedy that occurred thousands of miles away in New Jersey when your dad contracted COVID. Can you tell us about the challenges and how you weighed your personal and professional right in the midst of the biggest pandemic ever?
Absolutely. One of the more difficult things that you confront as a leader is knowing how to manage the multiple competing priorities for your attention and your time. And as I always say to our team, family always comes first. And you obviously learn, you spend a lot of time around family. I was always very close with my family, parents, grandparents. We were a very tight-knit group. And so when Dad, who had multiple chronic illnesses and was 80 years old at the time, called and said that he was a little bit not feeling well for a day or so in early April, late March, early April, 2 years ago, we were certainly concerned. He had multiple sclerosis. He was cared for at home by home healthcare workers and was pretty limited in terms of his ability to get out of a chair. And the next day he called at 5 a.m. to say he was short of breath. And I knew that portended some badness and some chaos. We tried to do a couple of things, including so many of the things that have now become common practice. I called his physician and said, let's get him some oxygen at home. He said, well, we can't do that. We need a doctor's order from a lung doctor. I'm like, what the heck? This is the craziest thing. Well, we need to send the nurse into the house. Well, we can't do that. And he lived in a very urban community in New Jersey, and we just couldn't find the secret sauce. And finally, I said, you have to go to the hospital. There is no choice. And so the wonderful EMS providers came and took him, and he was admitted and died 2 weeks later in that hospital bed that he was admitted to. And it was a terrible tragedy, Rhoda. Losing a parent is very difficult. Losing one under the circumstances that we faced with all of the uncertainty certainly created its own set of challenges. My dad was, I don't know that this is a laudable piece of information, but he was among the first 50,000 that died. We certainly were still trying to figure out what this meant in April of 2019. And so, wow, it was certainly a way to learn and adjust and make sure. And on the same day that I got word of my father's death, we were advancing our work in the community and trying to do some things when his doctor called and told me that he died. And so putting the personal and the professional elements together was certainly difficult and challenging, and something that I needed to learn how to deal with. Fortunately, I have a loving and caring family and wife, and my wife said to me, "You need to take the time off." Here I am, a doctor, an ICU doctor by background. And I'm like, "Well, what am I going to do if I sit home? I'm just going to think about him." And she said, "Exactly. We call that grieving. That's what you're supposed to do. You can't go to work. That's not the right thing. You're always telling your staff and you're telling your team and you're telling everyone, stay home and have appropriate work-life balance. How will it look if you don't do the same?" And so I stayed home for 3 days and mourned and thought about that. And it was the right work. It was the right thing to do at the time.
You know, there's so many ethical issues. You know, as the pandemic worsened last year, we saw health systems in the Midwest and the East especially shore a policy on care priorities, which some call rationing, and others who shall live and who shall not, which is actually rearing its ugly head in different parts of the country right now because it's out of control. We called off electives despite some serious medical concerns and more. Can you talk a little bit about the unthinkable, the potential rationing and impacts of delays of care on a national basis? Because there's a lot of ethics in that.
There sure are. And, you know, I think a couple of things I would say as a starter. We have to make sure that people understand the differentiation between the medical model, what we do as physicians, as nurses, as pharmacists. We are trained to care for people, one patient and one family at a time. Our entire effort goes into organizing our thoughts and advocating in the best interest of that individual. As you mentioned in the introduction, I'm also educated in the public health space. And when you're talking public health, it's not about the individual, family, or person. It's about what's in the greatest good for the population. And we have seen the tension point during the pandemic come right into the foreground in those conversations. People who continue to want to argue and energize around the individual's rights when in the context, and forget about the context of the public's rights. And what you come to understand in the context of a pandemic, which is one of the biggest public health challenges a society can ever face, is you bring to bear when there's a national disaster that's declared, when there's a statewide disaster, the rights of the individual are trumped for the rights of the greater good. That's what the emergency declarations do. And if you're doing your work appropriately in that sphere, what that allows you to do is to develop policies and procedures and guidelines and what we come to call crisis standards of care. And those crisis standards of care are operative in a pandemic because you don't want the individual nurse or doctor who's trying to advocate for the individual to be torn about what their responsibility is. So you in some ways make the policy decision from above and hand it down for implementation. And the chaos that we've experienced in the last 2 years is fundamentally about our lack of understanding of that tension point between the way that things currently usually operate, which is in a world of abundance in the United States healthcare system, and what we were faced with, which was a world of scarcity, when we did not know where the masks or the gowns or the ventilators or the doctors and nurses were going to come from. And in a world of scarcity, we are struck by the fact that we need guiding principles. And you need to make it up before you get into crisis, and we just didn't have those precursors. I think what's even more important is for those, here in the United States, we're not used to working in an element of scarcity. Although there are some in our society who are very familiar with that. If you talk about social determinants of health and not being able to access doctors and not being able to access medications or not being able to get food or housing, the major things that drive adversity in health, we come to understand that people in societies know that really, really well. But those of us who have not been subject to that want to rebut it and refute it every step of the way. And they typically are the most privileged, and that's what's gotten us into trouble over the last few years.
Absolutely. We live in our profession also in an era of misinformation, disinformation. And I want to talk about a challenge on December 1st of last year, when the Nevada governor disrupted your day and the global media wouldn't stop calling, and how you were able to handle that situation in a very classy way.
Well, just for everyone's background, on that day, Governor Sisolak called my cell phone, and we were in the middle of a health system board meeting, battling the pandemic, opened up our alternate care site. We're dealing with high census. So in order to set the context, you had to know that we were deep in the heat of battle. And in terms of combating COVID for our community and our state, and trying to make sure that we were doing all of the right things to the degree that we could, being short-staffed and short on the supplies and things that we needed. And the governor informed me that he said, "Tony, I want you to know that the president just released a tweet, and don't worry, I got you on this." And I said, "Governor, I have no idea what you're talking about. I'm in the middle of a board meeting. We're trying to combat COVID. I don't have a clue about a tweet. I'm pretty active on social media as a way of continuing to drive conversations with our employees and our community, but I had not caught up that day on social." And he said, "Well, don't worry about it. You'll find out soon enough." And we hung up, and he rebutted the president. At the time, called our alternate care site of care, which was established in our parking facility, 5 decks of our parking facility. 2 of them we outfitted to be a makeshift hospital and care for people during the COVID surge. And the president called our facility fake. And it was devastating. It was personally devastating at the time. You're fatigued, you're tired, you're bringing to bear all of your training, education, your goodwill, and your humanism to a fight that you know you can't conquer. And to have someone with that kind of authority, make a critical, offhanded comment, I felt to be disrespectful at the least. But most importantly, I couldn't remain quiet about that, because I, as the CEO for a health system, represent 7,500 committed employees and doctors who come to work every day to do the right thing. And it wasn't fair to them, no matter who the sender of the tweet was, to be called fake or to be called out for really working hard and trying to do the best they could for their community. And so we defended, not that you would expect we have to defend our work, we defended our work, and we took whatever criticism was going to come our way. But in the end of the day, we knew in our heart we were doing what was right for the people that we served, and that was all that mattered.
Well, thank you for that. In terms of doing what's right, the progress and the things, and I've got to call out my friend Suzanne Hendry, who's your CCO, CMO, who's an APR with PRSA, who is part of our group of 110, has really been terrific. And we're well aware of your great progress in diversity, equity, inclusion, and access. Too many people leave out the A in access, which you talked about beautifully in public health. It's where you live. Where you live depends on how long you're going to live. I mean, I grew up in Detroit, where it was a lot less survival in my community. So can you share some of the amazing activities, like your partnerships? I know so many of them because Tony has spoken to our group of 110 several times. And so one example that touched all our hearts is working with the clergy to help the undocumented receive worry-free needed COVID services, and how you are addressing inequities in access to care and health outcomes. So if you could talk a little bit about that, that'd be great.
Absolutely, Rhoda. It's interesting for me. There are we as an organization at Renown Health, I've now been the CEO for 7 years, and we have a tremendous commitment to what we call population health. for those of you that have been students of the Affordable Care Act back from the last two administrations ago, President Obama signed it into law in 2011. And we have really used as our guiding light the ability to serve all segments of our community differently. And whether you segment them by insurance status or lack of insurance status, of public insurance, Medicaid or Medicare, or whether you segment them by disease state or age group, our job is to meet the needs of that community more broadly. And we came to recognize during the COVID pandemic early on that there was a discrepancy in the way that many of our racial and ethnic communities had access to testing. And I like to say it like this, because it was only further accentuated in the aftermath of the George Floyd conversations that brought to light structural racism and some of the tensions that as a nation we experience. And I knew we weren't doing all that we could do. And I also came to know that, a middle-aged white guy may not be the best messenger for breaking down the barriers that inherently have people be suspicious about who might be coming to offer them services. And so we engaged with our clergy in a different way. And our Hispanic and our African-American clergy rose to the challenge of helping us to get out in the community and run mobile testing events. And we staffed them with volunteers, renowned health employees and others in the community, and offered free and same-day COVID testing at a time where this was long before we had come up with testing opportunities that were very broad. And then when the health department asked us again to provide vaccination to the community, because we know how limited the public health infrastructure is, we stepped up again to make sure that anyone who wanted it could get vaccination without having to share their license or their identification or their green card, because this is what makes people suspicious. This is what challenges them to come to the point of access and get the needed services, be it testing or vaccination that they needed. And so we were pleased and honored to play a very small part in that work in our community.
It's really important. Our members of our group there in San Diego have worked so hard at that right now the Hispanic community is much more vaccinated than the Caucasian community. And let's talk about democratization of health. You did the first US-based community population health study to democratize care beyond the physician orders, which really is for many an ethical issue. You took it on, and can you talk about that? Because it's really exciting.
I think, and wow, thank you, Rhoda, for bringing that up. One of the biggest challenges that is currently at risk in our nation is people's right to self-determination in a variety of ways. And the ability to offer people what previously has been only offered through a physician's order. And as Suzanne, as you mentioned earlier, and I talk often, I highlight the fact that the doctor's prescription pad has become a metaphor for limitations in access to healthcare. If the doctor thinks you should get it or not get it, they will or will not write you a prescription. Why? What about consumerism? What about people's right to self-determination? What about people's ability to make their own health and healthcare decisions in a way that is so meaningful for their life and their trajectory? Physicians and other healthcare professionals certainly have a responsibility and obligation to educate, to advocate, to work through challenges and questions, and to offer people what for them is in their right interest. And so when we opened up to the community free genetic testing, at the time we did this, we had 5,000 people put their hands up and signed up within 24 hours. We opened it up for another 5,000 slots, and 10,000 people signed up in 48 hours. We now have 65,000 people throughout Nevada that have given us their most precious resource, their DNA. And we've integrated with the clinical, social, environmental determinants of health in a database that's helping us to understand the health risks and challenges to our state's population. Nevada ranks 46th in the nation in terms of health status, and we have higher rates of mortality from cancer, lung disease, and cardiac disease in many, many other states. And this is an effort to change that and to break into the top 30 if we can over the next few years.
It's pretty spectacular. It's you know, and one of the things that I love about this is that you're really advancing equitable clinical care, and you're really looking at the issue of structural racism as a public health crisis. And so you advance, you know, you've really done. Anything else you want to say about that before we move on? Because you really are really reaching people.
Well, I'll tell you, you know, one of the things that is so, I think, interesting, again, we've learned so many things through the project. I've often said that the project provides us as a health system, it's one of the biggest strategic investments we could have ever made, because I know where women may be at risk for breast cancer because of their zip code. And I can put more mammography machines in those zip codes to allow for more enhanced screening for those women. Those are examples of where we want to go. And I think the elements of differentiation when you're talking at the population health level, whether it's racism or poverty, or we're challenged, as you mentioned in the introduction, Brown Health serves a broad geographic area of 100,000 square miles. We're the only tertiary health system between Sacramento and Salt Lake City. And with that, we understand the broad geography and the rural healthcare challenges. You know, when you have to drive 6 hours to a tertiary center in order to be able to get access to healthcare, it is just, you really have to think. And so going to the point about how we use population genetics and Healthy Nevada Project to democratize genetic testing, in those spaces, we're just trying to democratize healthcare because people don't have similar access that I happen to enjoy because I live down the block from a coronary center. And so using technology and opening up our eyes and our ears to what people were facing during COVID allowed us to more deliberately serve the needs of those underrepresented communities. And when you look across the nation, those communities that are served by rural or critical access or frontier hospitals are not a minority. There are 1,300, 1/3 of all the hospitals across the nation are actually critical access hospitals of 25 beds or less. Yet those communities are struggling. And with the economic challenges, we've seen how many of them have closed over the next year, but getting access to affordable healthcare throughout those vast landscapes that we serve in the nation are very important for us moving forward. So that's another area where people are differentiated based not necessarily on ethnicity or racism, but on geography. And being attentive to those discrepancies, I think, is important for us as we serve others.
It is so frustrating because when you look at the discrepancies of life, you know, in many communities, whether it be Philadelphia, Detroit, or a small rural community, you're looking at 20, 30% higher death rate because it's just not there. And it's just so frustrating. You know, you one of the things that you did too, you talk about philanthropy. And I remember when you all were giving grants and said, oh, we'll give some grants. And you had a ton of people apply. And tell everyone, I know, but tell everyone what you did, because I thought it was just so important and so meaningful.
Well, this was, I think, one of the things that we put our heads at Brown Health. One thing's for sure, we try to live our values every day. And we, you know, integrity and caring are so important, the two of our values, as we go through our work. And so when we were faced with the challenges of COVID, we stood up to assure that we wouldn't lay our employees off. It was a difficult time for people, but we had to be there. And I'm so proud of our leadership team and the members of our team that took a stance so that we could, and we were fortunate that we were able to do that work in the heat of battle when people were worried about where they were going and how they were going to live their own lives. And then in the aftermath of George Floyd, with the racial tensions that we experienced as a nation, we opened up a grant opportunity to break down the barriers of racism in our community. And so we provide small grants to other not-for-profits as a part of our community benefit work. And our community benefit team was so great in helping us to frame the ask. And we had, I want to say, I'm going by memory, Rhoda, but I want to say we had about 64 or so organizations apply, and we funded them all. We took every single project and funded them. And so when we were on the call, a Teams call like we're on now, what a great feeling. I'm actually getting goosebumps just talking about it. We had all of those participants log on and wait to hear who got funded. And I announced the name of every single organization. And it just wouldn't stop, one after another, all the way down to number 64. And when they realized that we made an announcement at the end that we funded them all for things that opened up a new way of thinking about race and ethnicity. Examples include ballet or gender inequalities, ballet dancing for boys in a dance school, using karate as an engagement tool for young students, and things like that, where not-for-profits came to serve the community differently and break down barriers to structural ignorances, if you will, we were so very proud to do that. And it demonstrated our caring and our integrity for our community.
Well, I think it's pretty wonderful. You know, we always think of the hospital as the forefront of care. And during COVID, there were millions of telehealth. Everyone was doing telehealth, and it is continuing at some pace. But you did something additionally. You did a hospital at home program to free up needed hospital beds, but also very important to keep many people, including frail, elderly, and others, in their home. Can you talk a little bit about that transition, which I think the rest of us are going to pick up and really look at this a lot more seriously?
Absolutely. So we have, Round Health has been a leader in telehealth for a long time. You are obligated, when you serve such a broad geographic area, to make sure you're making care convenient and easy to access across the board. And so for specialty care, we've served our rural communities with telehealth for a decade. In addition, we realized that telehealth became operative not only in rural communities, but down the street when we were in the throes of the pandemic. And how much better was it when people were anxious and nervous about coming into their doctor because they were afraid of transmission and afraid of how they were going to be getting exposed to the COVID virus, that we were able to offer these services right down the block. And that was really very helpful. What we also found out was we had this technology to monitor people at home. And the value of that is it enhanced our intrinsic capacity. One of the reasons I alluded to earlier that we opened up the parking facility was because it added 1,400 beds. That's a large number of beds. It actually doubled our capacity. Not quite in the way that we could provide it in the hospital, but in an alternative model where the public health crisis was rearing its head. And wow, if we could enhance that capability even more by keeping people in their home, where they were more comfortable, where they could eat their own food and watch their own TV and sit on their sofa or be in their bed and not in our bed, how much better would that be? And the lessons from my own experience with my father, where we could not get him oxygen at home, where we could not, that might have averted the hospitalization for a short time and kept him going without the need to go in. And so imagine for those people that we were serving differently, to offer that service was very, very rewarding. I think, I learned a long time ago, I tend to be pretty humble, and I have a group of family members and very close friends for many years who keep me humble. And always think of your family first as you're trying to solve the community's problems, and how might you rise up or hope to be treated as you serve others. And I think that's an important framework where our hospital and home strategy really worked, and how we're now monitoring people from home in a way that was very different than just a year ago.
Another thing, because of Becker's, I'm in constant communications with CEOs and with our own group. And I know that you were the first to do something that was very interesting. When COVID first started, we didn't want as many people as possible, not to work in the hospital, not to work in any of our long-term care or other, that didn't have to, because they were doing things that they didn't have to be in a hospital. As far as I know, when we first had you speak for the first, early last year, you were talking then not about the hybrid model, but you were talking about permanently moving hundreds of people, very early. You kind of saw this when the rest of us, and many people were still struggling with this, obviously, but what got you thinking that we're going to permanently put people at home? Because, the research now is showing that people can be much more productive, and they don't have to get ready, find a place to park, drive, whatever. What were your thoughts, and how is that going? And what do you think the future is of that?
I think we're not in a unique place. I mean, back in the time we started, we had about, I would say about 10%, 15% of our workforce started to work from home immediately. And
Yes.
we didn't even have teams in the health system. We had to implement it so that we could function in a way that was meaningful. Now it's second nature to so many of us, because whether it's Teams or Zoom or whatever platform you might like, we have that available. I think in some, my son, who's an accountant, CPA in Philadelphia, has been working for the same company, healthcare company, for the last 18 months. And this week was the first week he went into the office. Wow, he's never met his boss in person before. And I think that, especially with the younger generation, especially with the kinds of technology we have, those are opportunities. And we also see, I was on a phone call yesterday with 25 health system CEOs talking about our HR pressures and challenges moving forward. And people sometimes want the flexibility, but there are other differentials that, from a communication perspective, we have to make sure we're addressing. For example, some people want to know, well, if some worker, this came up yesterday in the call, if some workers are working from home and don't have to pay for parking, well, why should I have to pay for parking as an employee? And so it creates a whole new series of challenges that we have to make sure we're addressing comprehensively in our benefits, to assure that we're giving our employees an engagement opportunity that fulfills them and balances the life and work continuum.
Yeah, we hear a lot of that, especially from labor too, is that how do you equalize it, and have the right technology, and how much of it is permanent? So I think we're going to see a lot of, and speaking of the future, how are you predicting the future via analytics, artificial intelligence, to solve some of these workforce challenges, to solve some of the operations issues that you face, to ensure viability? Because for many of us in healthcare, it has been, there's a lot of losses, and and layoffs, and there's just been a lot of things going on that have been burnout, and it's been tough. So what are your thoughts on taking this to the future with all the analytics and other things that your technology?
Without a doubt, one of the great experiences I've had in my career has been the opportunity to be an outcomes or a health services researcher, we call it. And my expertise in that space is using large data sets to identify patterns in the data that other people might not actually understand. If you're in the doctor's brain can identify 2 or 3 connection points, but a pattern may come out of the data that the doctor never conceptualized. And wow, now we see AI algorithms and the ability to find those patterns in the data differently. It's in fact, Rhoda, why in 2016 we started the Healthy Nevada Project. We figured that if we put clinical data, genetic data, environmental data, and social data together, we would uncover patterns of illness and disease in our community that we never could conceptualize, and we have. We've identified the where and the whys and the hows. And I think even more broadly, you can't go now, I mean, not only are we on one device, we all have another device handy, and multiple devices at one time. And all of the data that is being elaborated from our interactions with one another and with devices is being kept. It's being kept and has, if I look at the positive side of it, tremendous power in being able to solve some of the world's biggest challenges. And so I believe that we will need mechanisms to learn how to serve more broadly. Let me give a specific example. I'm very passionate at the moment about our ability to do monitoring differently. As you mentioned, many providers, professionals are leaving the bedside in terms of career alternatives that are not in healthcare, doctors, nurses, pharmacists, therapists, etc. And so we have to learn how to work smarter. And that may mean that we use these AI algorithms to figure out who in our hospitals are most at risk of deterioration and deploy the right resources to their bedside in a way that's meaningful. And so these algorithms can incorporate many, many more bits of information than I as a doctor or some of my nursing colleagues can. And we can go right to the point of action and deploy resources that are not only the right skill set, but in the right quantity before the challenge actually deteriorates from that. So I think the future is bright for analytics and predictive analytics, as we call them, moving forward. And it will enhance our remote workforce capabilities, because now I can have nurses in a remote environment looking at large streams of data as they filter in and addressing the needs of those people who are sitting in a screen in front of them.
You know, healthcare has changed so much. When I started in healthcare, you had a cataract, we'd put sandbags on the side of your head and you'd stay in the hospital for 2 weeks, and now it's an outpatient. There's so many changes and challenges that we see in healthcare. And before the cloud, thank God for the cloud, because before that, we would treat all the heart patients the same. And now we can be so, as you're saying, so specific because of artificial intelligence and data to really look at that 34-year-old woman who has early stage breast cancer, and look at her environment and do that with others as well. So it's really exciting. You know, one question that I know around a lot of people's minds is the vaccination issue. I can tell you and I know there's some of my colleagues who are in that group of 100 and whatever that are on the call today, and every single call we talk about, what do you do? We find, we find influencers in the community. We talk to clergy, we talk to everyone we can, to get people vaccinated. I am sure that everyone on this call knows somebody that is anti-vaxxer, and we all know the thing, we should listen and whatever, but this is life and death. As you well know, Tony, nearly 100%, somewhere between 95 and 100 of people who are dying, the 3,000 to 4,000 people who are dying every day in our hospitals are unvaccinated. And I know there's a health system in Florida and they go up to the ICU and the guy's, getting off the vent, and he said, I wish, it's every day, I wish, we see the TV stories. What's your take? Because this is an ethical issue when people say it's freedom of whatever. And, but it's freedom of life and living and not having people die or sick. And what are your thoughts? That's just, I don't sleep at night thinking about this all the time.
Yeah, Rhoda, that's why the framing early in our conversation between medical model and public health model is so important for us. In general, our generation has never witnessed something like a public health crisis like we are in. And I think those words are getting thrown around for a variety of areas now, but nonetheless, the pandemic is a public health crisis. And in the context of a public health crisis, individual liberties are sacrificed for the benefit of the greater good. That's just how it works. And in fact, that's not about trying to discriminate. That's not about trying to, that's just how it works. When the president issues an emergency directive, or at the state level, when the governor issues an emergency directive, those directives are for the benefit of the most good that you can accomplish. And that's where vaccination falls in this context. But that's not opinion. That's, I mean, that is just years and years of understanding the difference. The challenge is, again, as a country, we've never faced something like this. So when you put the independence of the individual in the forefront of the conversation, you're not understanding the conversation accurately in the way that is, your individual rights do not get to trump the community's rights. I'm sorry, that's just not how it works in a global state of emergency. That's why we have law, that's why we have regulation. That's, the founding fathers, I guess at the time, that's what they designed, and that's where we are. It's a struggle, and some have argued that we haven't entered the negotiation correctly. I just got back from travel, and I was fascinated. Here in Nevada, we are actually pretty well off. People are wearing masks. People are isolating, they're distancing, they're doing the right stuff, they're washing their hands. And I was in a location on the East Coast over the weekend visiting family, and we struggled where you walked into a restaurant, none of the servers were wearing masks. None of the wait staff were wearing masks. None of the patrons were wearing masks. And walking through the mall, and none of them were wearing masks. And my wife said to me, wow, I feel so out of place. I can't believe that we are the only ones masking up. And I said, well, 2 weeks from now, we may be the only ones who aren't affected. So let's keep, even though we're vaccinated, even though that extra level of precaution, I have family members who are not vaccinated, and I'm blue in the face and trying to convince them and help them get over their biases for why. But it's a struggle still, and still all too prevalent around our nation.
I don't know if this is good news or not, but one of the, I serve in civic leadership capacity with the Air Force, and we were, one of the things we're finding is that we're requiring it, and so a lot more people are getting it. I've done a study of the first 20 health systems that required masking, and required vaccinations. One of the things we're finding is that the percentage is pretty tiny once people are getting vaccinated, but the population in general, listen, I wear a mask to the trash chute, which is 10 feet away. And so I think we all need to do a better job at this. We have a number, Tony, other things you want to say before we delve into questions that you want to address quickly?
I think that we are in an unthinkable place in time. And one of the most important things we can do, as I try to do every day in my leadership style, is just be authentic and be real and be humble and live my values and live. I often say everything I needed to learn how to live a good life, I learned from my grandmother by the time I was 5. And those principles stick with me every day. And they are the foundation of our ethics, and they are the foundation of how we try to lead, even through uncertain times.
One of the questions that people are asking, and I think we can deal with this, is someone asked what the group of 100 is. A group of 100 are health system communications and marketing executives at 110 health systems, representing about 80% of the hospitals. And so we got a couple chats and other things in there about people who want to get access to best practices, especially if you're in rural areas with vaccine. You can email me at rhoda@rhodaweiss.com. Our group has shared almost 3,000 best practices in a variety of things, even beyond COVID, and we'll share those kinds of things. Tony, someone had asked about what one of the biggest gaps in healthcare is mental health issues. And we are seeing, especially among children right now, and again, our group of 100 has a children's hospital group, and we're looking to do a national campaign on this topic. But you're seeing in your community mental health issues ranging from the doctors and nurses, having kids at home, kids, a lot of kid issues, a lot among everyone. What are your thoughts on, how we?
For those areas, Rhoda, where we have failed to invest as a nation for decades, this didn't come out of the blue, right? And so we've created, if you will, a public health crisis around mental illness. Why? Because of our ignorance of the problem for a long, long time. And now more than ever, so we've kind of created this crisis situation, and it's even more it's even more obvious now than it was ever before, because people have stress-induced anxiety and stress-induced depression, and stress around the uncertainty and the fear, and particularly to your point around children. I mean, I was employed by Children's National Medical Center in Washington, D.C. during 9/11. And we found in the aftermath of 9/11, the impact that the uncertainty created for those kids now 20 years ago. And it would be interesting to do some follow-up studies, how kids were able to overcome those challenges. But you can bet someday when you're sitting back sharing with friends, oh, remember COVID-19, how we've come through it as a nation or as communities, I think is going to be very important. And that includes the mental health sustainability and strength we have to derive from this.
Yeah, I know that a lot of the children's hospitals are trying to do a lot of work in this area. There's a question, and it's a question, I love the question, all the questions. What leadership lessons have you learned from the pandemic?
Yeah, this one, thank you for that question. This one is really simple for me. Sometimes it works against, but just be yourself. I'm just a kid from Jersey who came up, and my Jerseyisms comes through. And I actually do have a cousin, Vinny. I just am myself every day when I come to work. And I know that I can be myself around my core leadership team, who I surround myself with, so that I can be myself. And I just have to be real, and I have to be authentic. And I need to be in a place where people can be valued for letting me know I may have it wrong. And I'm fortunate in that I have a team that lets me know when I have it wrong in a very respectful and quiet way. But I think the humility helps to breed that kind of an environment. I'm so excited by that. That's what I do every day.
How are we going to coexist with the continuing pandemic? Because I don't know when it's going to stop, because people won't get vaccinated and wear masks, but how are we going to coexist with the continuing pandemic and a need to reinvent the future of healthcare?
Yeah, I think, to that point, it's a great question. I don't know how we're going to coexist. I know we're not moving fast enough. I know that we're not moving fast enough because the longer the pandemic goes on, the more and more the human resource challenges are going to affect us. So something came across my desk this morning from a blog about, many in healthcare believe now is the time to pause and slow down. And I disagree with that sentiment. I think we need to go even faster. And the challenge with going faster is everybody's tired, and everybody's burnt out, and everybody's had their own share of distress. And you feel like you're pushing people at a moment when they can't take anymore. And so being creative and innovative with those solutions and making sure we're finding the right opportunities for support, because people will engage with you if you create a vision for them. If you give them a shining star that we're going after together, people, I believe, will rise to the occasion. But you can't continue to put the challenges of this pandemic on the backs of your employees. It just will not work. We have to support them differently than we ever had before. And that takes creativity and innovation and humility to realize we got to do a little trial and error along the way, guys. This is not a book that we're going to pull off the shelf and play out. We've never seen something like this before.
You know, one thing, and this is kind of whatever, but and I wish I had a picture to show people, but you can go on their website and look at it, is the love statue. You know, people have statues of God knows what, you know, and you've got, can you talk about that? Because to me, ethics and misinformation, we all loved each other, corny baby boomers, we all loved each other, then maybe it would be okay.
It's so funny for me, you know, so we have an amazing love sculpture that was presented at Burning Man. Burning Man is a big public event in Nevada where people come from around the world, actually at Burning Man, to live life on what they call the playa, out in the desert with very little resources except for themselves in a communal setting. And the love statue is a very artsy environment. The love statue is this mega statue made out of steel. And it's very simple. I love art by you know, just to enjoy. And the love statue is elegant in its simplicity. 4 letters crafted out of steel. Something that in our heart means something so genuine, and yet is made out of a substance that is as hard as could be. And we are proudly displaying that the artist donated that, and through the generous support of a foundation in town, we were able to purchase the sculpture and put it on our campus. And I love it because I think we're too afraid to be genuine. We're too afraid to talk about love. Why? If the pandemic has done anything for me, it's to make me realize that I haven't loved enough, and I have to love more. And there's never enough time. You think you're given the gift of time. And I knew when the call came from my father, I knew what the story was. Live a life full of love. That's what we're here to do. And that's the foundation for any ethical principle we might bring forward.
You know, it's I like to think that beyond the concrete and steel framework of our hospitals or health facilities is that fragile human thread of life that's connected to us not only through medical and physical needs, but psychological, social, spiritual, practical needs as well. I remember my first day of it was like a million years ago, and the CEO said, never look at a patient as a person with a diseased tumor or a bad heart or a debilitating stroke, but as a human person attached to us through family, attitudes and emotions and joy. And I think, you know, my thing to all of you is we need your help. We need the help. In this organization are the greatest communicators ever. We need your help to get the word out, to help educate people about masks and vaccinations. Please, God, everybody wear a mask wherever you go, because you can get a breakthrough. And I can't tell you how many people I know that have breakthroughs. We need your help. The world needs your help. Use those skills, make a difference, because as the prophet Hillel said, if I am not for myself, who will be for me? But if I am not for others, who am I? And if not now, when? So now's the time. Tony, we just love you. You know that. All of us love you, who know you. And thank you for being with us today. Thank you for those of us who joined, and those of us who are going to see this afterwards. Stay well, stay healthy, wear that mask, and get your vaccination. Thank you, everyone.
Thank you,
Thank
Rhoda.
you, Tony.